Thank you very much, Alistair. Ladies and gentlemen, first, it's a pleasure for me to be here. It's in Dublin. It's the first time in Ireland. Nice country. First, we'll discuss the indication and results of VENO VENOUS ECMO for patients with severe respiratory failure. First, this is my COI slide. I'm working mainly with Mackay on a trial of VV ECMO for ARDS. We'll talk to you about that a little bit later today. Well, first, what is the rationale for using this technology in patients with severe respiratory failure? First, ECMO, VV ECMO can completely replace pulmonary function for those patients who are severely ill. That also rational to go with this technology early on to allow the lung to rest, and for those patients who have already developed ventilator-induced lung injury, maybe to allow healing of the lungs, putting the lungs at rest with the machine. This is not new technology. The concept was defined in the 60s by Kolobov and Zappel, who developed the first membrane oxygenator, and the first report of the use of this machine was in 1972 in a New England paper, Journal of Medicine paper. It was about a young man, 24 years old, who had blunt thoracic trauma and developed a shock lung. He got VA ECMO at that time, and he fully recovered. Here is the picture where it was taken at that time. Here you see the ECMO machine, which is this big barrel here, which needed up to 10 liters of full blood to be primed. This is a so-called Bramson ECMO machine, and we can even ask the question that these patients might even have survived despite the fact that he received ECMO, when knowing now all the lesion, potential lesion of trolley of transfusion associated lung injuries and all the problem with this machine. And following that these first cases, there was a randomized trial which was conducted by Warren Zappel in the USA, which was a failure. The mortality rate was over 90%, and following that, the technique was almost abandoned for at least 2 decades. Of course, this is now we can look back at these studies like it is a kind of history of medicine with a device from the 70s was only VA ECMO, and we now know that those patients with respiratory failure should always receive VV ECMO. The ECMO machine was weaned systematically at day 5. All the patients, it's very important here, all the patients that received prolonged mechanical ventilation before receiving VV ECMO probably have developed a severe lesion of ventilator lung injury before ECMO, and the mechanical ventilation was used at that time uses a high tidal volume, which might also have precipitated the evolution towards end-stage respiratory failure. And we have more studies coming, especially at the end of the 90s, and almost all the new stuff is coming from the last decade. Here's the famous paper by Bob Bartlett in JAMA 15 years ago, showing that for those patients who might benefit from the technique early on, the mortality might be lower than 50%. And when they evaluated at that time the predictors of mortality of these patients, they insisted on the time from the intubation to the time the patient received the ECMO machine. And probably for those patients who have the ECMO machine more than 1 week, after more than 1 week of mechanical ventilation, the prognosis is worse here, and mortality was multiplied by around 5. Similar data coming from the big ELSO registry paper published 6 years ago now, 1,500 patients, up to 50% survived to discharge. It was young patient at that time. And once again here, they found that the number of days on mechanical ventilation before ECMO was a strong predictor of survival, as was the fact of receiving VV as opposed to VA ECMO. And once again, the revival of the technique is coming from 2009 when ECMO strikes back, first with Giles here publishing the Caesar trial, which was conducted in the UK. At that time, there was only one center there gathering all the patients who received VV ECMO. It was patients with severe but potentially reversible ERDS, and the primary outcome of that trial was death or severe disability 6 months following randomization. And as you remember, this is not really a trial evaluating VV ECMO. It was a trial which evaluated transfer of patients for consideration of ECMO in the group, in the experimental group. And when looking here at the flow chart of that study, of the 90 patients which were transferred to Leicester for consideration of ECMO, only 68 received ECMO. 22 did not, because some of them improved with optimization of mechanical ventilation, and also 5 patients died either before or during transportation because, excuse me, at that time the patients were not transported under ECMO to Leicester. This is the first trial which was positive for patients who received VV ECMO. Here is the Kaplan-Meier showing that there was a better outcome for those patients who were transferred for consideration of ECMO to Leicester. Once again, here 6% of the patients died without ECMO, despite they were randomized in the ECMO group before, because there was no ECMO mobile rescue team in that study. And just about the same week, in September 2009, there was a publication of the first results of the ANZIX group treating patients with VV ECMO during the H1N1 pandemic. You also remember these very severe patients who had ERDS induced by the H1N1 virus, with here lungs which resemble liver, and they reported on a series of 68 patients on VV ECMO, and was mostly on VV. And those patients were quite sick when they received the device. The PF ratio was 56, and on high PEEP, high FiO2, and high peak pressure and hypercapnia at the time of VV ECMO initiation. And despite this great severity, the mortality was quite low at 25%. This is probably a different story, because here it's a specific disease with up to 1/3 of the patients were young patients with no comorbidities before inclusion in that registry, in case registry. The year after, with the publication of the experience of the UK group, at that time in England there was 4 ECMO centers, but it's the same strategy which was used in Caesar trial. So the patients were transferred to one of these 4 big centers for consideration of VV ECMO, and of the 80 patients transferred, only 60 got ECMO. They analyzed the data of these patients and compared the outcome of these patients to another group of patients were not transferred to one of these big centers, and they match cases and control using a propensity matching system or a gen match system. And they were able to show that those patients transferred to one of these big ECMO centers for consideration of ECMO had better outcome. Once again, the number of patients who received ECMO was around 75% of these 80 patients which were considered for ECMO. We also in France at that time built a registry with the RIVA group, and we analyzed the outcome of 123 patients who received ECMO during the 2 winters, 2010-2011, and we also compared cases and control with a matching system. And it's here all the beauty of statistics, depending on the way you match cases and control. Here on the right side, it's cases and control matched, which was made by the UK group, with the replacement. It means that you can match one control to several cases, and on the left here it's a more stringent matching strategy with matching without replacement. That means that only one control can be matched to a case, to one case, and depending on the strategy of matching, you can either find that there was a strong impact on survival for those patients who received ECMO or no impact. But on the left side here, for the most stringent strategy, less than half of the cases were matched, and those patients who were not matched were sicker and they had much better prognosis. So the conclusion of that is that it's almost impossible to draw strong conclusions from retrospective registries, because there's always one big confounder which is not controlled as to why patient A received ECMO and why patient B did not receive ECMO. You can use all this sophisticated matching strategy. There is always some factors which will not be controlled. We also derived interesting data from the way the patients were ventilated on VV ECMO in that cohort of patients. And the survivors here in the white bars were those for whom the plateau pressure was decreased below 25. And look here at the driving pressure, which also was much lower for those patients who survived. And here, the threshold is very close to the threshold was published by Marcelo Amato in the New England Journal of Paper, published a couple of weeks ago. So now, how can we improve the outcome of these patients who have severe ARDS? First, we need to adhere to guidelines and protocols, including early prone positioning for these patients. We also probably need to better select the population of patients who might benefit from this strategy. There are guidelines like these published by the ELSO, guidelines here from the Australian, from the New South Wales Ministry of Health in the state of Sydney. Very strict criteria here for going to VV ECMO, PF ratio below 100 with PCO2 over 100 for more than an hour, or a PF ratio below 60. It's almost a rescue strategy for patients who are very, very severe, almost dying from refractory hypoxemia. We also analyzed data from 3 centers in France, a series of 440 patients who got VV. Among these series, there was 64% survival, and we analyzed the predictors of survival to try to select those patients who might have the best prognosis following the initiation of ECMO, and we got a few here parameters which were gathered in a scoring system which was called the PRESERVE score, which might help define which population of patients might benefit the most from this strategy. And here, when breaking down the population of patients in quartiles of PRESERVE score, clearly we were able to define 4 groups of patients with quite different prognosis, and we might guess ask the question if those who have a high score might really benefit from the technique. Similar work was performed on the ELSO database, and there was another scoring system which has been called the RESP score, which was very similar to the PRESERVE. Here there was a website on which you can calculate, estimate the RESP score of your patient when you have to initiate ECMO and define if it's really a good choice to go for ECMO in these patients. So you can here, when entering the data, have the RESP score here, an estimated probability of survival, which might help in the decision. Last, probably we need to have big centers with high volume to get better results. We start to have now convincing evidence that the higher the number of cases in a center, the better is going to be the prognosis of the patients. Here is a series of pediatric patients showing that there was a constant improvement here in the survival with the number of cases performed every year, and there was a a paper from the ELSO registry was published in February, showing that there was also a strong volume outcome effect for pediatrics and adult patients on VV ECMO, maybe with a threshold around 30 for getting really good results in these patients. And it's probably strong incentive to have big centers with a mobile team, with a network of hospitals working together to gather patients in these big centers. And it was the purpose of one of the position paper we published as a group, which was recently formed with the International ECMO Network, which as the purpose of that initiative is to promote research in ECMO, and we also need more data now, and I hope we're going to have more data in the coming months from the trial we designed 6 years ago now, which is the EOLIA trial, which is testing VV ECMO in patients with severe ARDS. Here it's mainly here with this B item that the patients are randomized PF ratio below 80 with high FiO2 for more than 6 hours. And the primary endpoint of that trial is all-cause mortality at day 60. We have randomized 180 patients as of today, so I hope we might have the result of that trial in the coming months. Well, in conclusion, VV ECMO can rescue up to 50 to 80% of the patients with severe respiratory failure. We definitely need more data to confirm that this technology might help beyond the patients who are rescued because they are dying of refractory hypoxemia. I think here there's no question, but there might be a room for these technology for those patients who have severe ARDS but who are not dying of refractory hypoxemia. This was a matter of our EOLIA trial, and the controversy is still very active as of now, and we need more data. Thank you very much.
Thank you very much, Alain.